Do you have a good way to think about people who are like really indicated for TPN or PPN?
Yes. First of all, we always think about, okay, is a GI tract working? Can we do like enteral feeding? And what are the two causes of not having a GI tract working? It's either because you did not have enough absorption capacity, either because you got like several resection, or if you have severe like enteropathy, celiac disease, graft versus host, then until that gets fixed, you need to have IV support. So the length of the intestine, if the person has less than 100 centimeters of small bowel, or if there is severe villus atrophy. And then, is it moving? Because yes, we have gastroparesis that we can bypass with the J tube, but there are some people with scleroderma or severe neuromyopathic disorders that things are just not moving. So if they are getting tube feeds or food into their intestine, it will just like sit there, bloat them, ferment with the bacteria, and it will not be digested in a good way. So these are, I would say, the two main like indications to do TPN. And for the short term, if you have a patient that is very malnourished, that needs a surgery, that needs like cancer therapy, sometimes you would get to a better nutritional state by doing like TPN rather than to start tube feeds, or especially if they have like severe Crohn's disease, if they are obstructed, if they have lots of pain. Yes, in the short term, you can do TPN. I'm sorry, I did not mention that first. The first indication I mentioned are for people that will have perhaps long-term TPN. And in the short term, it's more if the patient is very malnourished and there is an obstruction or a GI condition that makes them unable to tolerate well enteral feeding.
I don't think I actually knew that less than 100 centimeters of gut would be like not enough gut to absorb things. But like good to think of like post-surgical as colon cancer patients or people who have like really bad diverticulitis that have parts of their gut missing.
Yeah, so the surgeon is usually telling you how much they remove, how much they feel is still in place. And it all depends on the quality of the bowel that is remaining. Some people are having like 120, 150 centimeters of small bowel, but they have severe vascular disease. And they are always in a kind of like chronic state of low grade ischemia, and they're not absorbing 100% of what they are eating. But a good rule of thumb is like 100 centimeter. And some people can have less, like 70 centimeters, if they have part of the colon that is still in place, because the colon is very helpful in absorbing short chain fatty acid and transforming some fibers into some good nutrients. So if you still have your colon, you can have even less small intestine and be off TPN.
I was just going to ask, like, how long do you typically see people on PPN or TPN, or is it like indefinite?
Yeah, PPN, usually we say less than 2 weeks because, again, like the veins are going to get thrombosed. There's going to be some phlebitis. It's as if you were having like nonstop some potassium in your vein. You cannot do that more than 2 weeks. And you cannot use the tiny catheter. It has to be between 7 and 20 centimeters long, 22G, and more in the basilic, cephalic vein. You cannot do peripheral parenteral nutrition in the hand vein. Like it has to be one of the relatively large one in the arm.
And I guess Hina was saying that like for TPN, it could be lifelong for some people if you're born with short gut syndrome or something like that.
Yeah, kids that had necrotizing enterocolitis, adults that has had like a very bad accident or some very bad like thrombosis of their mesenteric artery. In the past, people that had Crohn's disease before the biologic eras, they all get like less and less intestines to work with.